All right, moving on. So now we're moving to the neurology section. You'll see actually some of the meds we already talked about are going to fall into this category as well, which is good. So we have some good overlap here. First off, let's talk about epilepsy. What is epilepsy? Those are seizure disorders, right?
Chronic seizure.
Usually chronic seizures, right? Not just a single seizure, right? Different than febrile seizures, different than, eclampsia-related seizures, things like that. So, and basically what this is referring to is just abnormal sort of neuronal firing patterns, right? So you can think about arrhythmias in the heart, similar to what we think about epilepsy in the brain. And so it's actually interesting because some of the drugs we use for epilepsy actually got their start as antiarrhythmics. That makes sense when you look at the action potentials because they're actually very similar to one another. So just if you thought you could get away from action potentials and all the different phases, guess again, we're going to have to review it all over again. So hopefully you remember all that details because it's very important to know that. Anyway, and so again, when you're looking at kind of the collection of different types of seizures, where you get into like the term epilepsy essentially. And again, this is recurrence of seizures, right? And then we have status epilepticus. What is that? Basically continuous seizures or multiple seizures in a row where the patient does not get back to their baseline mental status, right? What do you call it when the patient's kind of, they've had the seizure, it's stopped, and now they're kind of this kind of loopy sort of state? Post-ictal state, right? So they don't leave that post-ictal state and have another seizure. That is status epilepticus, essentially, okay? Very, very serious because they start to develop cerebral ischemia that's going to cause even worse than brain damage, and they can die from that, right? Which is why oftentimes they end up getting intubated so we can breathe for them, even though if they still could be seizing potentially. Okay. So anyway, so we know there's a lot of different reasons why we can have seizures develop here. It could be, CNS infection. It could be due to patient getting older. It could be cancer. It could be a lot of different things. Drug-induced causes, though, there are a million of them, right? And so if we have a patient who presents with new onset seizures, and we're trying to run through our differential of things it could be, when you get to the drugs, it's a mile long, right? We have a whole one called Otis Campbell, just to show you how long of a mnemonic that we use in toxicology to go through our drug-induced causes of seizures. But some of the more common ones you run into include things like antidepressants, right? Like bupropion. That one's really well known for causing that, especially in overdose, right? Because again, you give antidepressants to someone to hopefully keep them from committing suicide, but then what is that black box warning for those? Suicidal ideations, right? Think about that. Alcohol withdrawal can cause seizures. Benzodiazepine withdrawal can cause seizures. Just like antiarrhythmics can cause arrhythmias, antiepileptics can cause seizures, right? So either the level's too high or too low. So anyway, so those are things we want to consider when you have a patient with seizures. Basically what you're finding is that the neurons are going to be hyper-excitable, and we're having this imbalance between GABA and glutamate, essentially. Okay, glutamate being excitatory, GABA being inhibitory. If you have too much glutamate around, you have seizures. If you have too much GABA around, you see CNS depression. Okay, so again, there's a delicate balance between those two. There are actually certain types of ingestions where they actually prevent your body from making GABA. And actually, you know what the precursor to GABA is? Glutamate. Glutamate turns into GABA, right? And so we actually have certain types of ingestion, certain mushrooms, where they can actually prevent that breakdown, that conversion from glutamate to GABA. And so if you lose GABA, guess what you have? Intractable seizures because they have so much glutamate around and no GABA to counterbalance it. Okay, so again, keep that relationship in mind between these two here. Anyway, so basically what we're finding is that normally when you have these action potentials occur, they're being propagated down the axon through these different nodes, right? And again, what's kind of the main ion flow that's happening here to cause this propagation? Sodium, right? Sodium influx, right? Remember, as the action potential comes along, causes sodium channels to open up, allows sodium to flow in, and that will cause further depolarization to occur. Okay, we're going to find this is a big target for our antiepileptics. So we already see that affecting GABA is going to be a big way we can do that. Affecting sodium channels is going to be a big way we can do that. So kind of keep these in mind here. Now, what we talk about the seizure threshold means how likely it is for someone to actually have that seizure there. So when we say we lower the threshold, what does that mean? They're more likely to have a seizure. If we're increasing that threshold, they're less likely to have that seizure, right? It seems a little counterintuitive when you think about it, but get a hang of that. So when I talk about things like antipsychotics, they lower the seizure threshold. They make it more likely to have one. If I talk about benzodiazepines, they increase that threshold, make it less likely to have a seizure because they're hyperpolarizing those cells by increasing all that chloride that's in there, right? They're so electronegative they can't have an action potential, okay? These are good things to know. And as well, remember when we talked about the cardiac conduction cycle, what prevented a new action potential from coming through and triggering off an arrhythmia? What do you call that period? The refractory period. The neurons have a refractory period as well. That refractory period is, say, too short. That could lead to a seizure essentially, right? Because again, it can be triggered off too soon, and once you have these kind of reentrant circuits starting to happen here, that's where you can have the seizure develop. So again, a lot of times what our drugs are doing is trying to extend that refractory period to make it less likely to have another action potential come along. Okay. So if we're using all these drugs to slow down the neurons to prevent them from having action potentials, what do you think is the main side effect of a lot of these antiepileptics? CNS depression. Absolutely right. So again, you're going to expect with all of these medications, you're going to be slowing down the CNS. You're going to see CNS depression. You're going to see ataxia. You're going to see nystagmus. You're going to see diplopia, etc., because of this mental slowing that you're causing here with these medications. Okay, that's a good thing to note about side effects. So anyway, when you're doing your diagnosis, obviously you want to get a really good history on these patients. You may need some additional imaging to find out what's going on. If they've had maybe an infarct, if they have cancer, causing a tumor to develop, anything. Labs are going to be super important here as well, right? So again, if you have too little sodium, hyponatremia can be a cause for seizures, right? I remember seeing several patients who would go to these boot camps, patients that never exercised a day in their life, and they say, you know what, I'm 50 now, it's time to get into shape. It's July in the middle of summer. Let's do this. And they go out and they just drink a ton of water, they don't get any sodium in, and they come in with a sodium of like 110 when it was seizures, right? So again, look at different causes. Hypoglycemia can present with seizures, right? If you don't have enough glucose in the brain, it can lead to seizures. So a lot of different causes here, a lot of things you have to rule out. And again, looking at the treatment for it, if they come in and they're hyponatremic, having seizures, how do you treat that? Give them some sodium, right? If you come in, they're hypoglycemic, having seizures, how do you treat that? Give them some glucose, right? So treat the obvious stuff first. If they're hypoxic, give them some oxygen, right? So again, look for the obvious stuff first, and then if they're still having these seizures, that's where medications are going to come into play, the typical sort of antiepileptics, right? Because again, if I have someone who has a sodium of 110, I can give them benzodiazepines all day long, not going to do anything because their sodium is so low, right? Those action potentials are just not going to be regulated very well. So anyway, so again, our goal is obviously to have no seizures. That would be beneficial. However, is that possible in all patients? No, some patients are going to still have seizures. Sometimes it's a goal of getting them down to fewer seizures in a day. So you have some of these kids who have, say, like mitochondrial or genetic, abnormalities being born, and they seize 20, 40, 60 times a day in some really severe cases. And so sometimes just getting them down to just having a couple seizures a day can be a huge, improvement in the quality of life for them potentially. Obviously, we like no side effects. Not going to be possible with a lot of these drugs. They have a lot of side effects associated with them. And then obviously we want to, try to, improve quality of life, et cetera. So that's mainly what we're going to be shooting for here. Now, what's the other problem if you think about like seizure treatment? How often do patients have between seizures? I don't know, right? So I could be treating a patient for 6 weeks, and they say, oh, I didn't have any seizures. Is it because they wouldn't have had any seizures, or is it because my drug's working? I don't know. I got this elephant repellent here. It's working great because there's no elephants around here, right? So it's kind of the same thing. So it's one of those things that's difficult to determine, is it the drug's working, or is it just they wouldn't have had a seizure anyway? So that can be one of the things that's hard to determine how efficacious the drugs are. However, you can definitely tell if there's side effects, right? So again, looking at drug levels and looking at what the patient's manifesting can lead you to think, okay, well, the drug could be working for the seizures, but they're having all those other side effects, may not be a good drug for them, as we'll see. Kinetics are a big thing to consider as well. So for instance, if you look at Phenytoin, did I ever give you a prescription assignment where you had to do Phenytoin based off the weight? I might do that in the future. But you have to look at the age of the child because the kinetics change, and so the dosing can change quite drastically, right? So for instance, what do you notice about the dosing here for these kids of different ages? Higher as they're younger. Why do you think that is? They're metabolizing it more rapidly. They actually have increased metabolism at earlier stages here than they do at these later stages, right? Which seems kind of counterintuitive with what we say about metabolism when they're very young. Usually slower in some cases, right? But this is one of those cases where they actually have an upregulation of these enzymes, where they require bigger doses. Okay. Also look at things like their other medical conditions. Look at their ability to comply with the medical regimen. Can they even get the medication? There's a lot of new antiepileptics that are out there. They're very expensive. If you can't pick it up, guess what? It's not all that effective of a drug because they can't take it. So consider all these different things. So first off, consider, did a seizure actually occur? And if it did, what type was it that actually happened here, right? So again, it could be just a generalized tonic-clonic. Was it a partial seizure that developed into a generalized? Was it an absent seizure? What's an absent seizure look like? Most of you probably have an absent seizure. It looks like it for at least these 2 hours during class here. Like it stops for like a 10-minute break right in the middle, and you come right back, and the seizure kicks right back in. Right? But again, it's good to know because drug therapy can differ depending on what type of seizure it actually was. So we'll talk about one drug in particular that is really only used for absent seizures in particular. So again, these are things to consider, right? And again, do you always have to treat with the first seizure? Maybe not, right? Depending on what the cause was. If it was due to they're doing too many amphetamines and had a seizure, well, they probably don't need continued seizure treatment because hopefully they're not going to do any more amphetamines, right? So look at the cause there. Can be a consideration. And then, think about monitoring parameters as well. We're going to see a lot of these drugs are pretty hard on the liver. Some of them are going to require renal elimination. So these are things you have to monitor for as well. So our drugs that we're going to have here, there's several different therapies, right? So we have anti-epileptic drugs. That'll be the mainstay of therapy. Those are effective for most patients. Most patients are going to be good with just one drug. However, some of them need 2, 3, 4, 5 drugs. I've seen a lot of some patients be on a whole cocktail of different drugs that maybe are still only getting them down to just a few seizures a day. So, right, they're very, very difficult to manage patients. Some patients require things like vagal nerve stimulators, surgery to actually remove certain foci, epileptic foci in the brain have to be removed sometimes. And then we have things like ketogenic diets, right? What is that? Low carb, almost no carb, right? What does that do for us? Makes you more acidic. What does that do for seizures? Increase the seizure threshold, right? And that's actually a really important consideration, especially for us in the hospital, because when patients are coming in on these medications, kids most often need what kind of medication? What dosage form? Liquid. Oh yeah, PO, but liquid specifically, right? And what do we put into a lot of our liquid medications to make them more palatable? Sugar, right? So again, you can't have any sugar-based products. We have to think about converting all their stuff over into either like dissolving tablets or IV medications or things like that to make sure we're not giving them too many carbs, because you have to account for carbs from every single source, including those medications there. Okay, little things to think about. So again, when you're determining what the optimal therapy is going to be, you have to look at things like drug interactions, adverse effects, mechanisms, etc. When you're combining different meds together, it's important to consider using complementary mechanisms and not using the same mechanism multiple times, because you're going to get very limited additional benefit there, right? So using 2 sodium channel blockers together doesn't make a whole lot of therapeutic sense versus if I were to mix something like a calcium channel blocker versus a sodium channel blocker, okay? That would make a little bit more therapeutic sense from that standpoint. Typically, as I mentioned, start off with monotherapy and then add on additional agents if those are not working. Most of the time, people need to stop therapy with a particular drug due to side effects, and we'll talk about what those are in just a few minutes here. Okay, generally, start low and titrate up, right? And you always give more medication if you need to. And again, usually it's going to be dependent on the patient, how well they're tolerating the medication as you go there. And again, what is the response to treatment? Would they not have had a seizure for that 6-week period, or is the medication actually working? Again, that's very difficult to determine there. Some of these drugs we'll mention need therapeutic drug monitoring. So we're actually going to monitor levels to make sure they're in the right therapeutic range. Now, just because someone's in the right range, does that mean that they are getting efficacy from that drug? Not necessarily. It doesn't mean they're not going to have any side effects from that drug. So again, that's just a helpful guide to let us know that, okay, they're at least in a range that we think is going to be effective, but may differ between every patient. So we'll talk about that a little bit. As I mentioned, if you're switching, try to consider using something of a different mechanism altogether. We'll get into those. So our main targets here, we're going to be focusing on sodium channel blockers. We'll have some calcium current inhibitors or calcium channel blockers. Again, these are different calcium channels than what we saw with, say, like verapamil or diltiazem, right? We'll talk about GABA enhancers, glutamate blockers, and we even have things like carbonic anhydrase inhibitors. What do you think? How do you think that works for seizures? We talked about carbonic anhydrase inhibitors. Makes you more acidic, right? Because what do you pee out? Bicarb, right? We talked about that as a acetazolamide used for as a diuretic, where you pee out bicarb because you can't reabsorb it. That causes you to be more acidic, and thus that can help to increase that seizure threshold. Again, we're not going to talk about all these in great detail, but the main ones we'll talk about, the more common ones you're going to run into. Okay, and then even some hormones can have an effect. Even things like estrogen can have an effect on a patient's seizures potentially, right? So you have to consider kind of all things here. Anyway, so looking at our targets, looking at a normal action potential that happens here. Normally when you have a stimulus come along, first thing that opens up are sodium channels. This is what causes the rapid depolarization here. And then how do you get this repolarization to occur? Potassium efflux, right? So again, potassium efflux, if you were to block potassium efflux here, you would extend this out potentially and change that refractory period. You're also going to see some calcium channels are getting involved here a little bit. We'll talk about those later. And then what kind of maintains that normal resting membrane potential? Sodium potassium ATPase pump, right? So remember that pump is used at all times in order to help retain this resting membrane potential. What do you think happens here during this hyperpolarization period? Well, yeah, so it's due to the outflow of potassium here, but remember, when you're hyperpolarized like this, are you able to have another action potential? It's very difficult, right? So that's part of that refractory period. And again, if we can have something that changes that resting membrane potential, say for instance, I have a benzo on board, you may find that instead of -70, maybe I'll bump it down and say -75 or -80. And that's going to, again, make it more difficult to have that seizure because it's going to be harder to hit that gate threshold there. Okay, so something to think about. Anyway, so sodium channel is very important. We're going to find that different antiepileptics work on different states of the sodium channel. We talked about this in cardiac a while ago, but there's resting, active, inactive. Just know whether a drug is a sodium channel blocker or not. That's as detailed as I want you to get as far as the mechanism go. Okay, but by blocking the sodium influx, you're preventing the action potential from occurring, or at least slowing it down. Okay. You can imagine here, you see that we're going to have several drugs that affect this, things like carbamazepine, phenytoin, lamotrigine. We'll get into all of these. And even you're going to find things like Valproic have multiple mechanisms. So some of them get a little interesting in the fact they can do different things all at the same time. But by focusing on this inactivated state, you're preventing any further sodium from coming in, and you're extending out that refractory period. Then we have our calcium channels. We have several different types that persist in the brain here. The main one we're shooting for here is actually going to be our T-type calcium channels. And these are actually going to be really important for absence seizures. And this is going to be important for one particular drug here called ethosuximide. And this is actually going to be the treatment of choice for absence seizures. It's like a really good board-style question. If you have a patient with absence seizures, what's the drug of choice? Always will say ethosuximide. It's a good thing to know, potentially. I don't know, maybe. Anyway, so calcium channel, by blocking calcium influx, normally that's a positive. That should increase our potential here. By blocking that in, again, you're going to extend that refractory period out and hopefully prevent that seizure from occurring. GABA, as I mentioned, we have GABA A and GABA B channels. Which one are we focusing on here, do you think? GABA A, right? GABA A is going to be our big thing we're focusing on. We talked about the benzos already and how they help to facilitate GABA to work better. We have several drugs as well that actually help to just directly open that channel. So we get into things like our barbiturates, like phenobarbital. That's actually going to directly open up that GABA channel to allow chloride to flow in. It actually is even more potent in causing the hyperpolarization than even the benzos would be by itself. But again, by decreasing that electric potential, by decreasing that resting membrane potential, it makes it more difficult to have the action potential trigger off because it's hyperpolarized, right? Again, GABA B is more important for the skeletal muscle relaxants. We're not going to talk about those here, but just know there's GABA B. Know that's used typically for those type of medications. So, again, there's several different things we can do to affect GABA. We can, one, directly affect the channel to allow GABA to work better. In the case of benzodiazepines, we can also do things like maybe decreasing the reuptake of GABA. If I decrease the reuptake, I have more GABA out in the synapse. More of it's available to interact with the receptors. Or I could do things like inhibit the breakdown of GABA. If I inhibit the metabolism of it, again, there's more that can sit there in the synapse and interact with those receptors, right? So there's several different ways we can affect this, and we'll look at a few different drugs that can work through that way. So for instance, like drug glytagabine can actually work by blocking the reuptake of GABA. Okay, so just know there's a few different mechanisms there to affect GABA generally. As I mentioned, there's this transaminase that metabolizes GABA. We have a drug that can inhibit that. And so just know we'll get into those specific drugs later, but they can all affect GABA a little bit differently. Here's a picture kind of showing that. Normally here we'd have a GABA transporter that is responsible for the reuptake of GABA. If you inhibit that, you have more in the synapse. You have things like benzodiazepines that will bind and directly allow GABA to work better, things that are affecting the metabolism of it, etc. So a lot of different ways we can affect GABA potentially, right? And so it would make sense potentially to use something like a benzo plus something like a reuptake inhibitor, because again, they can work synergistically together, right? Even though they both work through GABA, they have a little bit different mechanisms. You can see some synergy there, okay? Okay, and then we have our glutamate receptors. You said glutamate is normally what? Very excitatory, right? So again, if we can inhibit the activity of glutamate, that's going to be good. We have a lot of different types of glutamate receptors. I'm not going to get super in-depth on all of them, but we will talk about things like NMDA receptors. That's a very common one. We'll talk about AMPA-kainate ones potentially. But typically by blocking glutamate, you're helping to block that inward flow of sodium, okay? And actually also find a little bit extra outflow of potassium as well, which can help to hyperpolarize that cell, okay? Anyway, so getting into the drug specifically, there's over 20 that are available in the U.S. I'm not going to cover every single one of them here. I'm going to talk about the more common ones you're going to run into. But just know if you see a new one, you have this patient who's on just, this one, you're like, I've never even heard of that. That's okay, right? Because there's a lot of new antiepileptic drugs coming out all the time, right? And actually, what's a drug that's probably been around for the history of Earth? Hmm? Well, theophilin's not an anti-seizure med, but it's been around forever, but we're now using it more for seizures. Did you manage it? the natural substance? Marijuana. Yeah, your drug, I guess lithium's been around since the beginning of Earth. It's a metal, but not used for seizures. But marijuana, absolutely, right? The cannabidiol is actually good for certain types of seizures, as you'll find there, right? But they're seeing more and more patients are starting to use that for seizure management, right? So again, there's a lot of different products that are out there. I'm not going to cover every single one of them, but the common ones you're going to run into, definitely we're going to cover here, okay? Now, again, it's really difficult because every seizure patient's a little different as far as when they're going to have seizures and what affects their seizures. We don't really have any good head-to-head trials to say, like, oh yeah, phenytoin's way better than lamotrigine, which is way better than Keppra. We don't really have those studies here, right? You basically have to try to pick and choose based off side effects, based off of how the patient responds to, et cetera, to determine which one's really good for your patient, okay? So just know that everyone's going to respond a little bit differently. And I'll talk about some different trends and kind of how we're treating these as we go forward. Anyway, the first one is probably the kind of gold standard, like Mac Daddy, old OG sort of anti-epileptic that most people kind of grew up with. Is going to be Phenytoin or Dilantin. You're starting to see we're moving a little bit away from Phenytoin. We'll talk about the problems associated with it, but this is a pure sodium channel blocker. Okay, block sodium channels, prevents action potential from occurring. You stop the seizure, right? This is really good either for long-term management of seizures, preventing them, or we would use this for patients who were presenting to the ER with seizures. We can give this to them and actually stop an acute seizure from occurring, right? Or they're in status epilepticus, so we could use that. A lot of problems though with it, right? So you're going to find that the kinetics of it are such that there's a ton of drug interactions. They do things like induce CYP3A4. They can induce CYP2C families, right? They can affect things like warfarin. And they also find this highly protein bound. Why do we care about the highly protein bound nature of it? It can get kicked off. That's one thing. What else? What if someone has low serum proteins, right? Hypoalbuminemia could occur, and then now that fraction of free drug is higher than it would be otherwise. It means free drug is increased, which means what? More active drug, right? More active drug to interact with the sodium channels, right? So you can see patients who have a normal therapeutic level, they have hypoalbuminemia, and they're getting all these side effects from it. They're having all this ataxia and nystagmus and dizziness and all this kind of stuff, and you're trying to, like, what's going on here? Actually, it's due to the fact they have a higher free fraction of that drug, okay? So again, a lot of interactions here, a lot of issues we see with this, but it's really effective. It's useful for almost every type of seizure except for absent seizures. And that's what you're going to find with a lot of these. They're multi-purpose. They can be used for all types of different seizures. The absences are going to be kind of the one outlier there, right? Most of them are not going to have efficacy except for the ethosuximide I mentioned earlier. Anywho, but a lot of side effects are going to be very similar amongst the different anti-epileptics. You're going to see CNS slowing. You're going to see lethargy. You're going to see blurred vision. You're going to see all these things associated with that. Other things you can see with phenytoin, good things like hirsutism. You can see things like gingival hyperplasia. So you need really good oral hygiene to make sure it's not going to be a problem there. You can see things like vitamin D deficiencies. Osteomalacia can occur. So just know that a lot of side effects associated with it. Also, we're going to find a lot of these are associated with things like Stevens-Johnson syndrome. You guys remember what that is? What is that? You're like, I've heard of it. Yeah, it's that severe skin manifestation with the skin sloughing, blistering, potentially life-threatening if not caught early, right? We'll talk about one anti-epileptic especially that's really known for causing this, but phenytoin certainly can do it as well, right? Toxic epidermal necrolysis, Stevens-Johnson kind of go hand in hand there, right? So, and again, you don't have to know the dosing, but typically what we would do is we'd start off a patient on a loading dose. What's the benefit, or why do we do loading doses? You get them up to steady state quick, right? Immediately, right? So this drug has a longer half-life, so it takes time for it to get up to steady state. By giving a loading dose, you get them up there immediately, right? Because if I have a patient acutely seizing, do I want to wait 4 to 5 half-lives for them to get up to a therapeutic level? No, I want to treat them right now. So that's why we do loading doses for phenytoin typically. And so you give them a loading dose, get them up to the appropriate level, you stop the seizure, and then you can start to do maintenance dose and kind of prevent further seizures from occurring there. And so if you look at the ranges here, and again, I would give you the reference range, but I want you to understand the difference between these two levels here. We have what we call a total level and a free level. What's the difference between those two? One is showing not just protein bound, but all of the drug in the system, in the blood, free and bound and unbound. One of them is just showing the unbound form. So if I had a patient who had a therapeutic range total level, say it was 18, but the patient's having all this ataxia, they're feeling that the room is spinning, they can't stand up without almost falling over, what would you check next? Check a free level, and you find out, oh, it's actually like 2.3. It's too elevated, right? Because maybe their albumin levels are low, or maybe something else is a protein interaction where it's being kicked off.
Why wouldn't you just go with the free level?
It's a good question. Why wouldn't you just go with the free level? Well, for a long time, we didn't have free levels available. We'd actually have to do conversions based off of the albumin level. We'd have things we'd do, like kind of fudge the math a little bit to try to figure out what we think the free level is, and it's more expensive. So depending on where you work, you may not have as quick access to it. Nowadays, we're starting to move more and more towards, so you guys will probably have it easy and never have to worry about total levels. But in some cases, you may find it's more expensive. If you're just checking a level in the patient just to see like where the patient's at, total is probably fine. But if they're experiencing those side effects, or maybe they're having seizures, even though the total level looks fine, then it's an indication to go ahead and check a free level, right? So just something to consider there. That could be definitely off. And again, you can see it's about 90% protein bound, because again, 10% of it is that free level. So that's how I kind of think about the ranges there. From 10 to 20 is the total level. It's 90% protein bound. It means 10% is free, so 1 to 2 is the free level, right? And you get a feel for these levels if you work with these drugs very frequently. Again, I'm not going to have you memorize levels for the test, but just be able to interpret those if I give you a level on that test, okay? If I put the reference range on there. Anyway, and half-life can increase pretty drastically, so you have to be really careful with this. This undergoes what we call Michaelis-Menten kinetics, where basically, and we talked about this briefly back in the intro class many moons ago, but this thing can switch over from first-order kinetics to zero-order kinetics. What do you think that means? What's the difference there? Yeah, so it depends on if I'm metabolizing a certain percentage of drug per unit of time versus a certain just a baseline amount of drug per unit of time. Basically, what I can do is I can saturate these enzymes and make it so that the drug metabolism goes down very, very slow. So I had one patient we had who was coming in presenting for seizure. She was on phenytoin, but it was non-compliant. So levels low. So the ER resident decided I'm going to go ahead and order a loading dose for this patient and get her back up to therapeutic range. So it was right about 6:45 or so when the nurse was there, and she went ahead and gave the dose. And then what time does shift change? 7 and 7, right? So shift change occurred. Is now the new nurse coming on. She never got a report out that the patient had gotten the dose. Saw that on the chart that it's only to be given. So what did she do? She gives another loading dose. So now the patient is super toxic. She is sitting there and she's just like, what happened? The whole world's spinning. She's getting ready to be discharged, and now she just bought herself an admission, right? Because of medication error. Hopefully things like medical EMRs kind of help with that nowadays. We were still on paper charts at the time we were doing that, but just be aware. I'm going to make myself sound old one day when I'm like, oh, we were on paper charts back then, and old man Wood said they would watch out for them shift changes. Anyway, so the handoff is super important, you know, and those sorts of things. So hopefully EMR will help to prevent errors like that in the future. But if the nurse doesn't document something, she forgets, guess what? It's not there, and the errors like that can happen. So she ended up being in the hospital for 3 or 4 days while we were working on getting her levels back down to a therapeutic range. Right, not great. So just be aware that phenytoin is very kind of finicky from that sort of standpoint there. Anyway, things like hypoalbuminemia can affect this. The levels, renal failure, critically ill patients can all be affecting phenytoin levels. So again, that's kind of why we're moving away from it a little bit, is because it's so finicky of a drug that we're like, let's use something else. Maybe it's not quite so temperamental. And I'll give you some examples of those in a minute. The other thing you have to consider as well is that phenytoin cannot be given intramuscularly. It causes too much tissue necrosis. And in fact, if you extravasate the drug, when I say extravasate, what does that mean? It goes outside of the vein, so below the vein as I'm administering it, it can partition out to the tissue and actually cause severe tissue necrosis, called purple glove syndrome. And it's a pretty quick way to get a lawsuit against you, because it's going to require a lot of care to get that back, if you can get it back to normal. A lot of plastic surgery potentially involved with that. A lot of it is due to the fact that the drug is such a high pH. It's really hard to get it into solution. It's very, very not great on the veins. So what we would use instead is actually another kind of a cousin of phenytoin called phosphenytoin. Basically, you put a phosphate group on there, it makes it much more water soluble, and I can give it IM, I can give it IV, and I don't have to worry about the high pH and the extravasation, so it's really good. And so people are like, well, why would you ever use phenytoin? Why might I use phenytoin? Could be cheaper maybe, but nah, the safety profile is just such that I'm not really worried about the cost. What else? Drug shortages, right? If I don't have access to the phosphenytoin, and there's a case where for a while we couldn't get access to it because the manufacturer of it, there was glass particulate that was actually coming off the vial. So even though the drug was in good supply, the vials that were all out there had to be recalled. So that means we didn't have access to the drug for a while, so we had to switch back over to using phenytoin. So ways we got around that, we're trying to make sure that we're using a very deep vein if possible, central access if possible, right? So that way it's going right to the vena cava, where it can be diluted out very quickly. All those things we have to watch out for. So again, it can be very, very tenuous to administer this. And think about also little kids, their little tiny veins, very delicate, right? So again, very, very dangerous to administer this if you weren't really sure what you were doing with it, right? Anyway, so again, still a very effective drug. You still may see it used occasionally, okay? Up next, in our next sodium channel blocker, we have carbamazepine. Now, we already know something about carbamazepine because we talked about it where? For what other condition?
We just talked about Phenytoin.
For is a mood stabilizer, right? We're talking for bipolar disorder, right? Yeah, so we're using it for that. A lot of these antiepileptics will pull double duty as mood stabilizers. So carbamazepine is the first one out of this group. Now, what do we say we had to watch out for? What electrolyte? The good review for the test, right? Sodium. You gotta watch sodium. Why? SIADH, remember? Because that syndrome of inappropriate antidiuretic hormone caused sodium levels to go down because you have too much ADH being secreted. Think about that sort of thing. This also induces a ton of different CYP enzymes, so a ton of drug interactions. Induces 3A4, 2C9, 2C19. A lot of problems with that. You see things like agranulocytosis potentially with bone marrow suppression. You see things like hyponatremia that can develop here due to that SIADH I mentioned. LFT rises. So again, just know there's a lot of issues with this drug. However, it can be somewhat effective for some patients and may get pretty good effect from it, especially from a bipolar sort of standpoint. And again, we saw things like lithium have a whole host of other issues associated with that. So again, this could be preferable in some patients compared to lithium if you're using it as a mood stabilizer. Yeah, just be aware. And also, it induces its own metabolism, if you remember. So we also have to make sure we're kind of escalating the dose as we go along. Otherwise, levels will be too low and the patient could have another seizure potentially. The cousin to carbamazepine is oxcarbazepine. The big thing to note with this one is that it's going to have more hyponatremia associated with it due to higher risk for SIADH. So just be aware of that. Otherwise, it's actually a little bit better tolerated than carbamazepine. So fewer side effects associated with it and fewer drug interactions because it doesn't have the same autoinduction. It doesn't really induce a lot of CYP enzymes. Some people will prefer oxcarbazepine over carbamazepine because of that. Same mechanism of action, same sodium channel blockade you're going to see with that. Okay. Carbamazepine, you can do therapeutic drug monitoring on. We'll have levels available for that. Oxcarbazepine, you can't do levels on. So I'll just kind of mention that. You don't have to know specifically, does this drug have levels or not? But if I put it on the test, you should still be able to make an interpretation on it, right? If I give you the reference range, I tell you the level is 10 and the range is 4 to 12, you should be able to recognize that, okay, that's a therapeutic level, right? And be able to interpret it based off the rest of the case on there, okay? Anyway, up next I have valproic acid. So this one actually is probably better tolerated than our other sodium channel blockers we're already looking at, even though it does have its own host of issues there. And again, we saw this in use for bipolar disorder as well. This is actually one of the kind of go-to sort of mood stabilizers I'll see a lot of patients on because it is pretty well tolerated for the most part. And it has kind of a host of different activities that it does. It can block some sodium channels, block some calcium channels. It helps to make GABA a little bit more effective essentially. So a couple different things that it does. However, what are some of the toxicities we talked about? Hyperammonemia, absolutely. And what does hyperammonemia look like? Altered mental status, ataxia. What does overdoses of valproic acid look like, do you think? Same thing, all right. So again, sometimes it's hard to tell. Is it toxicity from the drug or is it toxicity from the ammonia, right? What do I give to help that ammonia level? Yeah, we give L-carnitine. Levocarnitine is going to be the thing that we can give to some patients in order to help keep ammonia down. Okay. What else can I worry about? Yep. So LFT. So hepatotoxicity is a big one. You have to watch out for this. And what else? Pancreatitis is actually a big cause for drug-induced pancreatitis. If you ever see that, it's something to consider there. Okay. All right. This one can inhibit CYP2C9, but not as significant of a number of interactions as you see with like phenytoin or carbamazepine. But this actually is an important one here of the effect on lamotrigine, another antiepileptic we'll talk about in a minute here. But they actually inhibit it inhibits the metabolism of lamotrigine, so you actually have to change your starting dose potentially. And so again, if I tell you like something like that on a test, and I was like, hey, this drug is inducing or inhibiting the metabolism of lamotrigine, how do you want to change the dose, right? And so you have to say, okay, well, I want to start at half the dose. I'll give you other options like you're going to double the dose or keep the same dose or things like that. So be able to make those interpretations. Okay. This one's also really teratogenic. Be really careful with this one because it can cause neural tube defects, right? What else causes neural tube defects? Yeah, folate deficiency is a big one you think about. So things to consider, if you're using this as a mood stabilizer for your patient with bipolar disorder, what are some of the things they do potentially? How's their decision-making process potentially? May not be great, right? Yeah. So this is one of those things where if they're on valproic acid, but maybe they're engaging in some high-risk sexual behaviors and they get pregnant, this is something you have to consider. Because again, when do patients know when they're pregnant? They know it like immediately? Sometimes they may not know until labor, actual labor is due, right? There's some of those TLC shows that are like, I didn't know I was pregnant. And it's just like, really? Like, dang. But yeah, it's one of those things where you have to consider, like, well, how much drug exposure actually occurred here, and you may not know for a good long time there, right? I was telling some people, I was like, for my first daughter, like, we knew it almost immediately because we were testing it every single month. It happened this month? No. It happened this month? No. When did it happen? He said, yeah, we knew about it immediately, right? The second one, we didn't know about it for a while, right? Because it's just like, I was like, man, why do you feel so crummy all the time? Why are you like throwing up? I was like, oh, we should probably go check a. I'll tell you, we probably spent more money on the pregnancy test for the first one. You know how much it cost us to figure out we were pregnant with the second one? $1. I went to the dollar store, and that thing lit up so bright. I was like, dang. And we love our little bundle of joy, but she's just a big surprise to us. I hope pray they'll never listen to these videos. All right. Anyway, and so again, real quick to go back over the benzodiazepines, these are going to be the #1 thing you're going to use for acute seizure management. Most patients may be on some of these for kind of chronic prevention of seizures, but these are your kind of go-to for acute seizures, okay? So again, most patients, if they have a seizure disorder, they're going to have an as-needed prescription for one of these to be used in case that they have a seizure, right? So just like you carry an EpiPen, if you have a history of anaphylactic reaction to peanuts or something, you would have a prescription for as-needed benzodiazepines. Now the problem is, like, who is going to administer this if you start to have a seizure? It's not going to be you, right? Because you're having a seizure. You can't really administer yourself rectal diazepam. Someone else has to do it, right? As opposed to if you're having an anaphylactic reaction, you can probably recognize that and give yourself an epi shot, real quick. So education is super important, right? So we do this a lot in the peds ER. We'd have a kid who gets diagnosed with new onset seizures. We have to educate them on how to use these medications because I don't know about you, but if I saw my little girls like having a seizure for the first or second time, I'd be pretty freaked out, right? I'd have a hard time like saying, okay, well, let's calm down, let's figure out what we need to do to administer this medication. That is important, right? Because again, delaying treatment can be problematic because again, if you're starving the brain of oxygen, it's not good. So, yes, sir. I have not encountered any of those people, but yeah, if they give that warning sign, potentially, if they can kind of sense that sort of prodrome of maybe a seizure onset, maybe they can take it beforehand. I've not actually considered that or thought about it. So.
I actually knew somebody that had a seizure dog.
Yep.
Said that the dog could detect when she was having a seizure up to 15 minutes before she.
Wow, that's super cool.
So she was actually able to drive. Because she knew, like, when she was gonna have a seizure, then she could pull over and park.
That's fantastic. Yeah. That's a big. It's a big hit on quality of life. If you have someone with seizures, they may not be able to drive because you have a seizure right in the middle of driving, right? That's fantastic. Yeah. So that's probably something they could probably take the dose beforehand, and that way they can hopefully avert it in the first place. Yeah, so something to consider. Very interesting. Anyway, so again, it goes to show the cats probably know you're gonna have a seizure, but they don't really care. They're like, whatever. The dogs are like, no, take something. No. Anyway. Yeah. Cats are like, oh, finally, if they die, I can have plenty of food for a while. No. So just real brief before I let you guys go. So these are good for as needed, like acute treatment of seizure, right? So this is kind of the first thing you're going to get if you have a seizure. So for instance, we would give patients something called Diastat. That's actually rectal diazepam. And that would be for, like, say, the parents or other caregivers to administer. Now, again, think logistically, it's kind of tough to do, right? You have to pull their pants down. You have to make sure you put the lubricant on the thing to actually give it. So it could be kind of tough. You have to make sure you can hold the cheek shut so that way they're not going to expel out the drug. And it was kind of problematic. So nowadays, what we're actually moving to is more using intranasal benzodiazepines. So a lot of our neurologists are now recommending intranasal Versed or midazolam. We'll give them the injectable product. They'll then draw that up. They'll then have an atomizing device, which is actually a little thing you screw on the end of a syringe, and it has like a little bit of like foam on it, so you can stick it up into the nose, and then it will atomize that device. Basically, it makes a really fine mist, and that way it can basically coat the nasal mucosa, get absorbed, and it works super, super well, just as well as any diazepam would do. So that's something you will see probably going forward. But if you ever see someone getting rectal diazepam, that's what it's for. It's usually as needed for seizures if they're to occur. Ativan is probably the most common one you're going to see being used for acute treatment of seizures in the hospital because it does have a pretty good activity. It's more water soluble, so one of the things it does is it takes longer to cross the blood-brain barrier, but once it's there, it sticks around for longer. So it's kind of nice from preventing recurrent seizures there. But really, any benzo is going to work, right? Because they all have the same mechanisms. They're all helping GABA to work better. They're going to hyperpolarize those neurons and prevent further action potentials from occurring. Okay. Keep in mind they're all controlled substances, they're all C4s, as we talked about before. Okay, I am seeing more kids on clobazam or Ompi as a chronic medicine. They'll actually take that every single day, 2 or 3 times a day potentially, and can help with kind of chronic maintenance. So you may see benzos being used for either, but primarily you're going to see things like Ativan, things like Versed being used for acute seizure management. Okay.
For chronic pain?
It was just for chronic management of the seizures, right? Chronic prevention of seizures. Okay. Right. So again, one of the questions that can come up is like, okay, well, say you have a patient who's gotten several doses, say 2 or 3 doses of Ativan. And say, well, what's the next step of management? We'll talk about that a little bit later about status epilepticus. But again, think about they've already gotten several doses of benzos. You got to go with a different mechanism because if the first 3 haven't worked, you got to switch it up to something else. So that's where oftentimes we'll start off with, like, say, 2 or 3 doses of Ativan. If they're still seizing, we'll start to go Phenytoin, or we'll do Keppra, which we'll talk about a little bit later, or we'll do Valproic acid or something like that. But that way you can switch up the mechanism and see if that's going to have an effect on that particular seizure. Okay, so just something to think about as far as the management goes. Right, so again, there's a lot of different routes. We talked about the adverse effects, sedation being the biggest one. And we talked about the withdrawal effects if they're on it chronically, right? So be very careful with that. If they're only on it as needed for seizures, they're not going to be taking it chronically, so you don't really have to worry about withdrawal effects in those cases there. Okay, it's only if they're taking like every single day scheduled, okay? Okay, so that's where I'm going to cut it for now. Any questions I can answer before I let you go? I'm sorry I held you over just a little bit. Try to be respectful of your time. But let me look at the board real quick.